Moore, Viral Hepatitis Program Director at the Tennessee Department of Health. Thank you, Heather. Viral Hepatitis Program Director for the Tennessee Department of Health, and I'm going to be your facilitator for today. Today's agenda will include introductions and announcements, a didactic presentation on on hepatitis C treatment evaluation, management, and post-treatment monitoring in adults by Dr. Cody Chastain. Time permitting, we're going to have 2 case presentations, both in adults, with a Q&A, and then some closing remarks. So first, some in-chat introductions, as well as some brief announcements. So before we get started, I would like everyone to take a second to introduce themselves in the chat. Please include your name, your role, your organization, and if this is your first ECHO session with us. I'm looking at the chat to see if there's anyone new. Not seeing that yet. Okay, Heather, can you go to the next slide? All right, so a few quick reminders I want to highlight that you may have seen when you joined the session. So I need everyone, including the subject matter experts and TDH team, to take 2 minutes to complete the sign-in sheet. You can utilize the QR code pictured here on the left of the slide or the website, which Shamia will put in the chat. The sign-in sheet is required for our accrediting body, and it's the only proof we will have of your attendance as far as they are concerned. If you don't complete the sign-in sheet, you will not be eligible for CE. And even if you do not want CE, we still need you to complete it. So I'll give everyone a minute to complete the sign-in sheet. And once you're done, please give me a thumbs up. There's also an exciting update that may be the last time you have to hear that announcement, because we're going to be changing our accrediting body from the ECHO Institute to the Southeast AIDS Education Training Center. Some more information regarding that is forthcoming. Dr. Chastain, would you like to give your evaluation announcement, maybe for the last time in this format?
Sure. All of you, thank you for being here. Most importantly, I appreciate your engagement and your willingness to participate in a Department of Health led program. The Southeast AIDS Education Training Center supports me in doing education like this, as well as additional programming related to HIV and other comorbid conditions. If you are so willing to, while you're listening to me drone on in just a couple of minutes, fill out a couple more registration pieces of information, that would be incredibly helpful to our team as far as demonstrating the work that we do. Clove Tipton has just dropped that additional link in the box. If you've participated in any of our programming before, it's relatively short and painless. Thank you so much.
Thank you, Dr. Chastain. All right, I'm seeing a few thumbs up. I'll give it another minute. So yes, this is exciting. This is going to be changing, but for today, we do have to do this. So please do it. We would really appreciate it. All right, I'll give it a few more seconds and then we're going to move on. Okay, Heather, next slide, please. All right, so please turn on your video and mute yourself unless speaking. And so I've gotten some feedback that is confusing. So please turn on your video always if you're willing, and just keep yourself muted until you're going to speak. We would love to see all of your faces and engage with you. And certainly please come off mute to ask any questions that you may have. Anastasia, has anyone joined by phone only?
Yes, there is a phone number in the list. If your phone number is 865-803-1412, can you please identify yourself?
If you joined by phone, can you please come off mute and identify yourself? Okay. Next slide, please. All right, as a reminder, please never discuss PHI and please treat everyone with respect. A couple of announcements. There's an upcoming webinar this Friday by the National AIDS Treatment Advocacy Project, where they will be providing an update on the elimination of hepatitis C. And this will include the federal and White House Hep C elimination plans. And so to register, please use the QR code on the left. And I'll give, if Heather, if you'll go back for 1 second, I just want to give everybody a chance to get out their phone and snap the QR code if you want. And also, okay, thank you. And Mia has put it in the chat. All right, next slide. We also just learned of the CDC Find Hepatitis C Treatment widget. So to access this, please use the QR code on the top right. And if you're treating for Hep C, please consider adding your organization using the QR code on the bottom right. And Mia has also put this in the chat. Thank you, Mia. Next slide. And finally, our ECHO website is still down. We are really, really actively working to get it back up and running. Nothing bad happened. It's just an unfortunate oversight. So hopefully that will be up and running soon. And as soon as it's back up and running, we will email the listserv and let everyone know. So with that, I'm going to turn it over to Dr. Chastain for today's didactic presentation.
Hey everybody, thanks again for joining us this, I guess, afternoon, unless you are joining somewhere far west of here. We're going to talk about hepatitis C treatment evaluation, management, post-treatment monitoring today. Again, I'm Cody Chastain. I'm an infectious diseases physician at Vanderbilt University Medical Center. Next slide will tell you that I have no financial disclosures or conflicts of interest to report. And in this next slide, I just want to remind you all that we do have a variety of topics that we've already addressed as part of this series. Some of you have been with us all the way through, others of you have only recently joined, but you can connect with Mia, Lindsay, the rest of the TDH ECHO team, especially after that website is back up, because we do have materials related to screening and diagnosis, linkage to care, and hepatitis C virus resources, both for adults and children, initial hepatitis C evaluation, again, both for adults and children, and initial hepatitis C virus treatment selection. Once again, adults and children. So we've had a variety of topics we've already hit. What we're actually going to move into today is you've screened someone, you've diagnosed them, they've engaged in care, hopefully with you or someone else in your community. They've completed the upfront evaluation for their hepatitis C, and actually you've selected a therapy and have to successfully navigate the process of obtaining that therapy, initiating that therapy. What we're going to focus on during this short discussion is about, well, what comes next as far as monitoring that process, particularly among adults. We can move to the next slide. And I think it's always important to tell you what you're going to be able to know. After this next 10 to 15 minutes, you will be able to apply guideline recommendations for hepatitis C treatment monitoring, and also recommend appropriate care after successful HCV treatments. Next slide. All the data that I'm going to share with you and all the recommendations I want to share with you are from the American Association for the Study of Liver Diseases and the Infectious Diseases Society of America guidelines. And there's a particular section titled Monitoring Patients Who are Starting Hepatitis C Treatment, are on treatment, or have completed therapy. While this image is a relatively old visual of how the titles used to look in the guidelines, the information in the title is still the same place, the same website. Next slide. One thing that I want to highlight up front is some of the terminology that we use in the context of treatment. When we're talking about timelines of initiating therapy and also laboratory studies that are sent, a lot of times what we talk about is baseline, the time period antecedent to any treatment initiation. Once treatment starts, we often refer to it as the treatment period or part of the treatment duration, and then there's that follow-up subsequently. And this is an image from hepatitisc.uw.edu that specifically highlights what monitoring over an 8-week course of hepatitis C treatment may look like, with the hepatitis C viral load along the y-axis, where it is relatively elevated at the baseline initial treatment period, drops substantially, typically by week 4, and then hopefully remains undetectable beyond that period of time, all the way out to a point where we define a sustained virologic response, or SVR. Next slide. You can see that, one slide back, a 12-week period looks almost identical, except that the final laboratory checkpoint where you're assessing for sustained virologic response might be 4 weeks further into the future. Next slide. This is why some of the terminology gets complicated. We have that baseline period where laboratory studies may be assessed prior to initiating treatment. You have the treatment period, and then you have that timeline or date of end of treatment. From that point in time, we typically count the number of weeks after someone takes their last effective dose of hepatitis C therapy, and we wait to see, is there any detectable hepatitis C that remains in the bloodstream off of therapy for a period of time. A sustained virologic response 12 weeks after completing therapy is referred to SVR12. And a sustained virologic response 24 weeks after therapy is so-called SVR24. But as you note, SVR12 lands on 24 weeks after starting therapy, and SVR24 lands 36 weeks after starting therapy. So again, when we talk about sustained virologic response or SVR, what we're really referring to is how many weeks was that laboratory test sent after completing their last effective dose of treatment. Next slide. So the first thing to think about is when someone is on hepatitis C therapy is how often do they need to be seen while they are on treatment? And specific quote from the hepatitis C guidelines, clinic visits or telephone contact are recommended to ensure medication adherence and to monitor for adverse effects and potential drug-drug interactions, especially with newly prescribed medications. I think what's important to highlight here is that there's nothing in this statement that says anything about laboratory assessments. It is all about making sure that patients who are currently being treated with hepatitis C medicines are able to take it, are being effectively supported through any adverse effects they may have occurred, and also that there's a check-in opportunity to make sure that there have been no new medications initiated in addition to hepatitis C therapy that could interact and cause additional complications. That could be done in person. That could be done through a virtual telemedicine visit. That could be done by a phone visit. That could be done by a medical provider. That could be performed by another health professional adjunctive in that office. Could be done by a pharmacist. Could be done by a variety of patient navigators or additional support services. I think what they highlight here is that what's critical is that patients have the opportunity to engage in additional layers of support. Next slide. In my practice, I generally try to supplement or replace provider in-person appointments with either pharmacy virtual or phone follow-up for side effect or adverse effect monitoring and adherence counseling. I try to minimize the barriers or the need for patients to present for additional care if it's not needed or necessary. That being said, a patient has adverse effects, a patient struggling with adherence, or if they need additional support in any way, I certainly want to see those patients and engage those patients face-to-face in any way possible if I can be helpful. It's trying to right-size the intervention for the patient and or family. Next slide. What's the recommended laboratory assessment while someone's on hepatitis C therapy? Well, I've highlighted the weeks here, week 2 of therapy, week 4 of therapy, week 8 of therapy, week 12 of therapy, end of treatment, as well as a sustained virologic response, 12 weeks or beyond. And I've highlighted some of the key things here. If you're using ribavirin, you might use complete blood count at week 2, as well as week 4. If you have a patient who is symptomatic while on therapy or has significantly elevated baseline LFTs, you could consider a hepatic function panel. At week 4, you could consider checking a hepatitis C RNA polymerase chain reaction if there's concerns about adherence. At week 8, if you're using ribavirin or another medicine combination called elbasvir-grazoprevir, you might send additional lab studies. That's also true at week 12 if you're using an extended course of elbasvir-grazoprevir. Perhaps at the end of treatment, if you had a patient who struggled with adherence or had an atypical complicated clinical course, you may choose to check a hepatitis C RNA PCR. However, a lot of these you see repeatedly are consider, or are related to specific medications that may require additional monitoring. We can move to the next slide. And what I've highlighted here is that the only laboratory test that is recommended for all people after starting hepatitis C therapy is actually checking a hepatitis C virus RNA polymerase chain reaction 12 weeks or more beyond the end of treatment. That's actually the only lab study that's recommended for all persons who are treated, because other studies really are only needed depending on the specific medication and or based on clinical course. And that's really important because this is a way to decrease the burden and cost both to the patient engaging in healthcare as well as a non-traditional or non-specialty treatment site. Next slide. What if you encounter elevated liver function tests while on therapy? Well, first of all, the question is, why did you check it? Because you have to make sure that you're interpreting the laboratory studies appropriately. Historically, we routinely check this based on guidelines, but as I just showed you, liver function tests are not routinely recommended for all patients. If you have a patient who has a remarkably elevated liver function test at baseline, you may choose to check it on follow-up to ensure that it is downtrending, that there may not be another liver-related medical condition that is driving liver inflammation. If liver function tests or LFTs are greater than 10 times the upper limit of normal while on therapy, it's recommended to stop treatment. Rarely, hepatitis C therapy can negatively contribute to adverse effects, but it is quite rare. If you have a patient with liver function tests that are elevated, but less than 10 times above the limit of normal, and they are asymptomatic, then the recommendation is repeat labs at 2-week intervals to ensure that those are downtrending. On the other hand, if the patient has evidence or symptoms of acute hepatitis, including weakness, nausea, vomiting, jaundice, or decompensated disease, which may reflect in that same way, as well as laboratory increases of bilirubin, alkaline phosphatase, and or INR, is recommended to stop therapy. Now, this all comes with a very important caveat. What was the patient's baseline before they started therapy? Are you treating a patient who had liver function tests that were greater than the 10 times the upper limit normal before you even started the treatment? Well, if that's the case, and their liver function tests have not remarkably increased, you may still continue therapy. What if you're treating a patient with decompensated cirrhosis and they already had symptoms of jaundice, weakness, elevated bilirubin, alkaline phosphatase, and elevated INR? Well, you aren't going to stop therapy. You would have to incorporate those laboratory studies into your clinical context. Next slide. Another question is that at times people may choose to check a viral load while on therapy. This historically was a pretty common practice when direct-acting antivirals were first introduced, and actually was part of the routine recommendations. Almost all patients on modern, current generation direct-acting antivirals will have an undetectable hepatitis C viral load at week 4. If it's checked and it's not undetectable, you need to consider compliance or adherence with the medication regimen, as well as if there's any drug-drug interactions. But what's important is that there's no real clear recommendations for how to interpret this or to do further testing. So if you have a patient who's had a clinical response with a lower viral load, what we found is that in patients who have detectable viral loads at week 4, but have still had a significant response, the vast majority of those are still cured with standard durations of therapy. If you have a patient who expresses that they're not adherent to their regimen, that might be an altogether different story. A detectable viral load in this context at least can give you a leverage for additional discussion. But again, it's very rare that it will actually change management. Next slide. If a patient fails to clear during or after treatment, for instance, a patient who's appropriately adherent to therapy, no significant drug-drug interactions, takes their therapy consistently, and you assess for a sustained virologic response 12 weeks or greater after, and there's detectable hepatitis C viral load, and you do not suspect new infections or new exposures, then the question is, well, what do you do next? We can move on to the next slide, which really is just, we should monitor for liver injury and/or liver failure cancer as appropriate. Next. We can consider reasons for failure as well as options for retreatment. And I want to highlight that today we have multiple options that are approved and recommended for retreatment. There's no clear role for resistance testing prior to the first episode of retreatment. However, if you're using an atypical regimen, or if you have a patient with particularly severe disease and are having to use an atypical regimen, resistance testing may inform an expert treater in how they move forward, but resistance testing is relatively rare in when it will actually modify or enhance a retreatment recommendation. With that, we can move to the next slide, which I believe is a buffer slide for me to pause here. echo pause for Lindsay, about whether there's questions about on-treatment monitoring. And you can unmute or put questions in the chat.
So Dr. Chastain, there's one question in the chat from Dr. Allen. What would you consider a detectable viral load?
So Dr. Allen is poking the bear here. So what does a detectable viral load mean? So there was probably 3 different interpretations you could actually come up with a viral load lab. You can have one that is called undetected or not detected, that there's no evidence of virus present. That's what we want for our patients. That's what we strive for on all of our laboratory studies. There's also another viral load report that might say detected, but less than the lower limit that can be quantified, whether it be 15, 20, or 40. That's still a sign of great response. On treatment, not concerned about that. On the other hand, at a sustained virologic response assessment, if hepatitis C is detected, which means that there's detectable genetic material of the virus 12 weeks after you finish medicine, that's concerning to me that they may not have cleared. So I would feel very differently about a week 4 laboratory test that said detected, but less than whatever the lower limit of quantification, as opposed to how I would feel about that at a sustained virological response, where I would be much more concerned. And last but not least, if you get above the quantifiable limit, the actual a numeric value will actually be reported, whether it be 20, 40, 1,000, 500,000, a million. And again, interpreting that in the context, if a patient drops from 1 million to 25 over 4 weeks of therapy, that's still a great response. On the other hand, if someone started at 5,000 and is now only 2,000 4 weeks into therapy or at end of treatment, that is obviously concerning. Clark, additional comments there?
Yeah, I was just going to give an example. I've got a patient who started out at 9 million and she's down to 50. I mean, it's still, I would say, detectable, but I'm not concerned. But I just wanted to kind of see what your thoughts would be on what a detectable lab would be. 50, I would say, is fine. I wanted to kind of get what your feelings would be.
Yeah, it's a great question. And we actually, I worked with a group of pharmacists and other clinicians here at Vanderbilt, and we actually published a paper about low detectable viral loads while on treatment. And again, did not demonstrate any significant drop in SVR rate among those who had low-level viremia, those patients with double-digit viral loads or even low-level triple-digit viral loads, as compared to patients who had undetectable viral loads, as opposed to those patients who had viral loads in the thousands or greater, which really questioned absorption, adherence, and or drug interactions. Dr. Alfaro-Cruz?
Yes, and so I kind of want to, because we had this a little bit of discussion from a pediatric case that we presented where the patient actually had, I think it was like 3 million something, and then we retested, it showed less than 15 units per ml. And then we were talking about that, and the question was whether that was considered still a cure or not detectable. And so it was kind of a tricky part because we talked about how every lab will report in a different way. And for that patient specifically, that value that they gave us was actually, when we look at the comment, it says non-Hep C detected or non-viral Hep C detected in that. So I think it kind of goes what you're saying, that it's going to depend a lot of how the lab will describe it. And I think Lindsay also made a comment about that, because we are expecting, to see 0 or non-detected, but I think it will depend a lot on how the lab is running the test too.
Those are great points.
There's also one more comment. So from Dr. Miller, are episodes of increased LFTs common that you have seen or with clinical trials, or perhaps related to other external factors such as HIV meds, et cetera?
It's a great point, and I think a really important one. And also, I think it gives, I think your question really is the explanation for why guidance has changed. Early on with direct-acting antivirals, particularly with early generation direct-acting antivirals, there were a small select number of patients who did have LFT abnormalities that were probably attributable to medications. That was particularly relevant with Cimeprevir, a first-generation protease inhibitor, as well as the regimen that preceded glecaprevir, trade name Mavred. That was the so-called PROD regimen, paratepravir boosted with ritonavir, ombedisvir, desavivir. a handful of pills that you took twice a day that only was effective for genotype 1. And the protease inhibitors were attributed to cause LFT abnormalities in at least a small select group of patients. However, with our current generation of therapies, sofosbuvir, velpatasvir, sofosbuvir, ledipasvir, glecaprevir, LFT elevations are attributed to those medications are quite rare. And what really has been found in subsequent clinical studies is that traditional monitoring, including labs while on therapy versus minimal monitoring, no labs on therapy, really did not change the safety profile for patients. And so in that context, in the greater scheme, in the real world, elevated LFTs on therapy, I would look for a different reason. I would look for alcohol. I would look for other medications. I would look for other substance use. I would look for other explanations of hepatitis C medicine being the cause of elevated liver function tests, and a patient who already has an underlying liver disease and may have other comorbid conditions is by no means my leading thing on my differential. It might be a diagnosis of exclusion. It should be my differential diagnosis, but because it's become so rare for this to be attributed to hepatitis C medicines, that is partly why the guidelines have moved towards trying to reduce barriers of additional laboratory testing while on therapy.
Awesome. Thank you,
Great
Dr.
questions.
Chastain. No more questions in the chat.
Okay, well, I'll move on just to wrap this section up. That was treatment on monitoring. The question is what comes after monitoring? So we can move to the next slide. And after sustained virologic response is achieved, then counseling I provide to my patients is that their hepatitis C antibody will remain positive lifelong. This is a sign of exposure and immune activation, not necessarily an evidence of infection. I counsel my patients that reinfection is possible if they are exposed to contaminated blood or body fluid, and if they are concerned about exposure, that they need to be tested with a nucleic acid-based test rather than antibody tests, because again, their antibody test will be positive the rest of their life. And then the last piece I have to think about, does this person require any ongoing liver monitoring? And if we move to the next slide, or at the bottom half of the slide, if a patient at baseline has no significant fibrosis, considered no fibrosis, minimal fibrosis, or mild fibrosis, F0 to F2 on a Medivir scoring system, they can be followed as if they were never infected moving forward as per the SLD and IDSA guidance. However, if a patient has cirrhosis, equivalent of F4 disease, ongoing hepatocellular carcinoma screening with an ultrasound every 6 months, a CT abdomen with triple phase contrast annually, or MRI abdomen with contrast annually is currently recommended. Now, this is debated because we need to have a longer follow-up time in larger populations to determine, is this cost effective and is this making an impact for those patients who are 10 years or 15 years beyond hepatitis C treatment. But at this point, hepatocellular carcinoma screening is recommended for those patients with F4 or cirrhosis. GI or hepatology referral for upper endoscopy is appropriate for those patients with advanced fibrosis under standard clinical circumstances. But there are some controversies in this last slide. We'll note this. It's like, if we move to the next, apologies. I wanted to highlight a couple things from the simplified guidance before controversies. Simplified guidance, again, is a great tool for all of us to use and to lean on for the majority of our cases, because even the follow-up plans are detailed here. We can move up to the next slide. I've drilled down to the bottom third, and it actually tells you again, you can check hepatitis C RNA. The current guidance also states that hepatic function panels recommend 12 weeks or later to assess transaminase normalization. If you have a patient at baseline, though, that has normal LFTs, you don't need to necessarily get that. And ultimately, if you have LFT abnormalities that are elevated post-cure, but they're cured, that actually questions another aspect altogether. So the reason I did not list it earlier in my slides is that if you have a patient with baseline LFTs that are normal, you may not require a hepatic function panel. Follow-up after virologic cure, those without cirrhosis do not require anything further, and that's what's detailed here. And there's some additional pieces about counseling. The next slide is actually the guidance about with cirrhosis. And again, the only thing that's different from the prior slide to this one is really recommending hepatocellular carcinoma screening as well as upper endoscopy surveillance as appropriate. We can move to the next slide. And I think the areas of uncertainty that I tried to preface a couple slides ago is that the indications frequency of future hepatocellular carcinoma screening is being evaluated. Currently, it's recommended for all patients with F4 or cirrhosis. That may change in the future based on additional studies and data. What do you do with that non-specific staging? What if you have a patient who has F2 to F3 or has F3 fibrosis? Not exactly certain about the best way to address those patients. I tend to, if I have a patient with F3 fibrosis or worse on their pre-staging, I err on the side of caution and ensure that those patients have adequate follow-up and monitoring. The other piece is a lot of times patients, for a variety of reasons, engage in hepatitis C evaluation and care and get treated quickly, which is great, but sometimes they don't get a full baseline non-invasive staging assessment, whether it be with full laboratory assessments, liver biopsies, transient elastography, or other tools. And some of those non-invasive staging tools have not been validated to be used post-treatment. And so this is where I always tell people, this is why I'm really focused on trying to get the best staging data prior to treatment, because that's when we get the most validation about how those non-invasive staging tools perform. That allows me to get the best recommendations to my patients at the end of treatment. That being said, we don't want perfect to be enemy of good. If patients have completed treatment and been successfully cured, that's the most important thing for them. Then you have to use expert guidance and also interpretation of literature about determining what degree of fibrosis that person has based on the additional pieces. I think the last slide, which is after this, is just follow-up questions. I see that there is a question for Dr. Allen about questions about alpha-fetoprotein or not for hepatocellular carcinoma screening in addition to ultrasound. This is a plus minus, Dr. Allen. This is something that has been recommended in some hepatology literature, and then there's other guidance and groups that do not recommend alpha-fetoprotein. If you go to the IDSA guidelines, they specifically say ultrasound with or without alpha-fetoprotein, so they kind of leave an open gate for that. I think the challenge is that there are a variety of different factors that can change alpha-fetoprotein levels that are not hepatocellular carcinoma. On the flip side, alpha-fetoproteins can be useful in interpreting masses that have been identified or subsequent treatment responses. I will say that out of the hepatologists I've worked collaboratively with in the past, I think it's been about 50-50 as far as those who have sent it out routinely with their hepatocellular carcinoma screening and those who have not. Dr. Alfaro Cruz, I would certainly welcome your opinion, although I recognize that you work with younger patients than my adult hepatology colleagues.
Yes, usually we don't tend to send AFP levels, to be honest. We have very low suspicion for our patients. But again, we've had that issue, kind of a debate when they're talking about guidelines in children, whether this will be beneficial or no. But right now, the consensus is that we should not, unless there is a high clinical suspicion for liver cancer.
Great, thank you. Shamia, I know you have a question, and I know it's probably the same one that I have, so I'm going to turn it to you.
Yeah, so we got another question in the chat just asking, you mentioned, Dr. Chastain, about reinfection, and I know that there are more than one genotype, and so can a person be reinfected with the same genotype, and does that change kind of what your treatment plan is going to be?
I apologize, Mia. It broke up on my end. Do you mind repeating the question?
Sure. Essentially, you mentioned about reinfection. And so can a person be reinfected with the same genotype? And if yes, does that change your plan of treatment?
Yeah, it's a great question because when we were trying to discern reinfection versus persistent failure of prior treatment, that's a genotype sometimes can help us distinguish between the two. For instance, if someone was treated with genotype 1 disease, treated with an appropriate regimen, appeared to fail, but then subsequently on taking additional history, you find that that person had additional intervening risk factors, and now they have genotype 2 or genotype 3. That's pretty clear evidence that that person has been infected with a new infection and may be treated as if they've never been infected before using a treatment-naive guidance. On the other hand, if you have a patient who's genotype 1, has persistently detectable viral loads after, has intervening risk factors, and you check a genotype and genotype 1 again, then you have to use clinical intuition and also the information available to you, whether you think that this was a treatment failure or if you think it was a reinfection. If it's a treatment failure, you would pivot onto retreatment regimens, whether it's you get clear evidence that this was reinfection, which is very difficult to ascertain if it's the same genotype. You may consider treating with, again, a first-line regimen. So this is often a clinical case, which is why we're here. This is why we're here to have these case discussions. So if you have a patient who you're concerned about reinfection versus other complications, that's a perfect case, as well as any other case to bring to this group. All right, I'm wrapped, Mia.
Love it. All right, and then, sorry, just as a reminder, you can always direct questions to Echo